Hello and welcome to Mental Health Matters.
I'm Barbara Myers. On today's show, we're going to focus on a comprehensive program for mental health. It's called the Advantage Program. Our guests are two of the creators of the program and one of the clients. First, I'd like to introduce Tom Wootton, who is the president of Bipolar Advantage. He's the author of Bipolar Advantage and the Depression Advantage, two books, and the leader of workshops on mental health in many different venues. He lives with bipolar in order, a term that he will explain to us on the show. Welcome, Tom.
Thank you very much.
I'd like to introduce Dr. Peter Forster. He's the medical director of the Bipolar Advantage program. He's a clinical professor of psychiatry at the University of California in San Francisco and past president of the Northern Californian Psychiatric Society, and also a distinguished fellow of the American Psychiatric Association. Welcome, Peter. And finally, I'd like to introduce Will Meacham, MD, who is a client of Bipolar Advantage. So welcome, Will. I'd like to talk to you, Tom and Peter, about what the Advantage program is. Can you describe the program and the approach that it takes?
Well, there's two main ideas around the Advantage program. One is that we can achieve results beyond what normal people would think of. We can actually have a great life instead of accepting a diminished life. And the second part of that is having an integrated approach that combines the expertise from a whole variety of sources that work on all of us: our physical, mental, emotional, spiritual, our relationships, and our careers and finances.
What I think I've heard you say before is that you can turn your condition into something that has been a disadvantage in order for it to be an advantage, and this is what you mean by bipolar in order. Is that right?
Bipolar in order is kind of the opposite of disorder. So when bipolar is in disorder, our lives are completely messed up by it, and our reaction to the symptoms are controlled by the condition itself. Bipolar in order signifies that we understand it to the point that it no longer controls us. But that doesn't mean we've gotten rid of all of the symptoms, because to me that means we live a diminished life in fear that someday it's going to come back.
That's a very novel and interesting approach, and I gather that it's one that you arrived at through your own personal experience, so that's the best example, I think.
That's true. My experience has been through the Advantage program itself, by combining the resources of great doctors and medicine along with spiritual help, hard work on my own part, nutrition, and all kinds of other things.
So how does this approach differ from other approaches? I have a picture here that we're going to put up to show the different dimensions that exist in a plan. Tell us what's happening with all of these comprehensive pieces of the plan.
Well, like I said, we're looking at the whole person: physical, mental, emotional, spiritual, relationships, and career. And what we did is we went out and found some of the experts in all of those fields to address it. So there's an organization called American Association of Pastoral Counselors that is talking about spiritual counsel different from join my religion.
Right.
They're saying no matter what religion the spiritual counselor is from, they're trained to address the psychological elements that talk about somebody's sense of purpose and meaning in life.
Right.
Then we've got medical doctors, nutritionists, and fitness trainers to look at the physical aspect, psychiatrists, support groups, things like that to handle the mental part, psychotherapists and support groups and such to handle the emotional part, relationship coaching and peer counseling to help with the relationship part, and then professionals, both life coaches, career coaches, and financial planners to look at the financial career parts.
Yeah, that's really comprehensive. So if someone first comes to you, how does it work? Do you have them evaluated in each of these areas?
What we do is we assign them what we call a peer advocate, somebody who helps them to assemble their team. Everybody has different needs, and everybody has different aspects of their life that they want to address. What we do is help match them to the resources that are available.
Okay.
If it's local within the San Francisco Bay Area, we have our own team, but more often people are from all over the country or all over the world. We help them find local resources.
Do you work with people with specific mental conditions or substance abuse, or you have any particular types of clients you work with?
Well, basically, we focus on working with people who have mood disorders, so depression, whether bipolar depression or unipolar depression, often also people with post-traumatic stress disorder, and occasionally other conditions, anxiety conditions primarily. So the idea is we are working with people who have those problems as the common thread that ties them together. But then we also try to address all of their needs. So we know, for instance, that people with bipolar, almost half of them have a substance abuse co-occurring disorder or condition. And so, of course, we have substance abuse counselors, and all of us are expert in working with folks with substance abuse because we understand that that's some of what may happen to folks with depression. So the idea is we start with this core group, and then we add the pieces that we need in terms of completing a treatment approach.
What do you see as the role of psychiatric medication?
Well, I think that psychiatric medication is something that helps many people deal with mood symptoms that are out of control. So it helps them achieve a sense of stability and the ability to begin to do some of the other things that Tom mentions. Often when people come into the program, they may have a very clear idea, you know, my life is out of control, I need some help right now, I want a medication. And although we often talk about alternatives, most of the time people are pretty clear that they want to see if a medication can't help them because they feel that they've been trying other things a lot and it hasn't worked. So then we will start them on a medication, but also we'll start them learning about their moods. Because a lot of the time when we see folks who've been on medications, those medications haven't worked, and often that's because there hasn't been enough information available to the doctor and the patient to make sensible decisions, because mood symptoms vary a lot. Unless you're keeping track of that, it's really a matter of how did you feel when the day you went to see your doctor. And if that was a good day, the medications were working, and if that was a bad day, then they weren't. And
so you teach them how to keep track of, on a day-by-day basis of what's happening.
Exactly.
Okay. What does the personal advocate do, Tom?
Personal advocate tries to find out what the needs are of the individual because they're confused as to where do I go for services. So what we have is peers, people who actually have this condition, who have been through the gamut, who can help them make sound decisions. So they'll come to us saying, we don't know what to do, we've tried this or that, but we're at a state where we don't really have the knowledge to make good decisions for resources. And what we do is we help educate them, but also even make the phone calls and interview some of the professionals to help hook them up with them.
To find the best match.
So we're actually advocating on their behalf with the medical and other communities, the support systems, to help them find that. Sometimes it's as simple as calling their own pastor at their own church and talking to them about the importance of them helping. My own personal experience at my own church is they said, we can't help you with your spiritual issues, you have to go handle your psychological issues first. And we're trying to help them understand that working the spiritual issues in conjunction with the psychological issues is the better path.
I agree with that completely, yes. Who are the service providers that you have doing all of these different jobs? Have you interviewed them, or how do you select the ones that are part of your program?
Well, in the Bay Area, we have service providers that we've already interviewed, and we've actually been working together with them to develop the program. Outside of the Bay Area, we use resources, we have directories, people who know people, that kind of information to identify providers that we think will be able to work in an integrated fashion. And that's kind of one of the key pieces, is that we really want the whole team to be communicating with each other and with the patient.
So you have the different service providers know who all the other service providers are that the patient is working with. And then they can communicate with each other about the client if they need to.
Well, actually, we set up a secure website with the patient's permission that allows each person secure access to shared information, so they can message, they can share notes, questions, concerns, and it's all shared also with the patient.
As a patient myself, I love it because I get to see what they're saying, and I even get to comment on, we had this meeting together. My doctor has his opinion of what happened. I get to add my opinion also.
That's cool.
We're all communicating together as a team.
What about availability? I guess you've talked about when someone doesn't live in the Bay Area, so you handle that by...
Yeah, it's primarily done by the peer advocate, but all of the rest of the folks who are in the Bay Area, we all have resources through professional societies and people that we know and that we've met. So sort of all chip in to help find resources.
Good. Okay.
Our core team is actually one of the people in our core teams in Miami, Florida, because Maureen Duffy taught at Barry University there, and she's one of the foremost experts at relationship counseling. So we actually also do some over-the-phone help for people who can't find the resources in their own areas.
Could somebody create their own program, now that they know what the pieces are in a program? Could they create their own program with, say, their currently existing psychiatrist and their minister and maybe a few other folks? Or what do you think about that?
Absolutely. What we're trying to do is we're trying to educate people, to show them the 2 points I made earlier. One, we should change our expected outcomes. We should look at we're capable of having a great life. Don't accept that I'm never going to amount to anything and I'm going to suffer from this condition for the rest of my life. And that's what we call a paradigm change. We're trying to get people to make the effort to improve their lives. The other piece is getting them to recognize that you need to gather all of these pieces together. Someone who makes that paradigm shift could go out and assemble their own team by themselves. All we're doing is saying we need to, for society, we need to start making changes towards those two things, integrated approach and better outcomes.
And Tom, I understand you have an unconventional view of symptoms and how the clients experience them. Can you tell how it differs from assumptions of a current medical model that people might be familiar with?
The mainstream idea is that we have symptoms, and the way to handle this is to get rid of all of the symptoms. So, for example, I have symptoms that would indicate that I have depression. The idea is if we can remove all of those symptoms, I will no longer have depression. My idea is that for the rest of my life, I'm going to be in fear of those symptoms ever returning. And when they do, I'm not going to have any skill set to how to deal with them. So what we've looked at is taking those symptoms in the current definition and separating out the symptoms of the feelings. I have physical pain, mental pain, emotional pain, spiritual pain from our reactions to them. And in terms of symptom management, what we want to do is help people remove those reaction symptoms, not so much the actual pain that they're experiencing. That means I can go through these states that we would call depressive, but not have the normal reactions to them. That's a major change in the way that we see it.
How does this work in your own life?
In my life, what I at first did was the standard idea. Let's get rid of all of the symptoms. Let's have no mania, no depression. So if depression's at the bottom and none is in the middle and this is high mania out of control, we end up with this minimal life where we have no highs and no lows because any of those in either direction is a symptom that we want to avoid. Well, those of us that have these conditions and have reached that state don't call that a victory. We call it boredom. We don't want to stay there. We want to learn how to expand our range of experience so we can have the normal highs and lows of normal people. What our problem is we want to be able to control those so that they're not causing the other symptoms, our inability to handle them, our bad behaviors.
So you've been able to make that work in your own life?
In my own life, I started out with a pretty narrow range, and it slowly grew. Over time, it grew more and more.
So you work at sort of stretching that range?
We're using all of the tools available, medicine, psychotherapy, and otherwise, to stay within a range that we can function in. And we're starting to recognize where the limits of that range are. Well, as we learn and grow, we start finding that those limits start to get further. We find that we can experience some depressions that used to make us unable to function at all. We can function just fine in them now. Over time, that range grows. A very controversial idea is, where's the limit? Some people would say there's some line that when you reach that, you can't get any further. My own experience has been that line is ever moving. We can experience deeper and deeper levels of depression, or higher and higher levels of mania, or in my case, more and more hallucinations without them controlling our lives. That takes an incredible amount of work on the person with the condition, and it takes an incredible amount of help with the whole team to make that happen.
Yes, I was going to ask Peter, what do you think about Tom's approach to managing symptoms?
Well, I think it's great for Tom, and it may be great for others as well. For me, it's sort of a goal is to help people expand what they're able to deal with and to function with as little support as they can, and hopefully as little of that support being medications with adverse side effects as possible. But I think that needs to take place within a context, within a safe context. So the people that I've seen who've had problems have been people who say, well, that's it, I'm feeling good, I don't need to see you anymore, I don't need to take my medications anymore, I don't need to do any of these things because now I'm finally feeling good. And that often doesn't work. But people who've been successful are people who say, well, this is the direction I want to go in, let's make changes in that direction and see, am I able to cope with and deal with and adapt to a larger range of mood. And I agree with Tom. I mean, I saw someone today who's very high functioning, but incredibly afraid of even the smallest change in his mood. He's got a very narrow range where he's a little bit hypomanic, but not too much hypomanic. And that's the only thing he's comfortable with. If he dips it all down into depression, he calls me right away, and he's terrified. And I think, over time, what we want to do is to have people like that use mindfulness meditation, yoga, other techniques to develop more of an ability to tolerate the normal fluctuations in mood.
And I'm kind of the pioneer. I'm the one with a deep spiritual background. I lived in a monastery, and I have the training and the background for it. I'm the one looking for how far the range can be. No one has been studying how far can we go. I'm a pioneer on my own, and there's a handful of others. So we don't know what the range is. My range is remarkably further than most people would consider possible. I'm living proof that it is. But like Peter said, there's a huge responsibility to staying within a range that we can control. We don't want to cross that line into some place that we can't handle it. And we do flip out and can't function very well.
Okay, well, thank you. Now I'd like to talk with Will. Tell us a little bit about yourself and your story and what led you to enroll in the Advantage program.
I came from a background that set me up for mood problems. I had a real traumatic upbringing, and I also have a strong family history of mood problems. So really very early on, I started having a lot of difficulty with depression, although it alternated with hypomania quite frequently. I was a so-called rapid cycler. I didn't know some of those terms, but I worked with those problems most of my adult life, and by the time I was around 40, I felt like I had it pretty well worked out. I finally, in my late 30s, broke down and took medications, and I was in therapy, and things were going okay, and then I suffered a major loss. I had some medical problems, and I had to give up my medical career, which was, of course, hard. It would be hard for anyone, I think, and for someone that had kind of unstable moods, it really was destabilizing. And so I had a couple of hospitalizations, one for depression and one for pretty severe mania. And then I had about a 5-year period where things were pretty deadened for me. I was heavily medicated and not happy. My moods were very constrained. It was a really, minimal existence, just barely going. So the medications were not working real well for me because I think I was on too much. And then I changed my care actually into an HMO into Kaiser, and they had a program that had more resources than the psychiatrist I was working with on the outside, and I learned things like cognitive behavioral therapy and so on, dialectic behavior and therapy, and they trained me a little bit in meditation and got me to start doing some of the things that we're talking about, exercise and better diet, and I got a lot better. And around 2008, I started feeling well enough that I thought I had something to offer to others, and so I got in touch with Tom. And his first, question for me, actually, when we were still talking by email, was, would you like to be involved as a client in the program? And my attitude was, well, I'm fine. I've solved most of my problems. My moods are under control. I know what I'm doing. And he was okay with that, and we met and we talked, and I just got to know more of the philosophy, and it started to sound attractive to me, and I realized that there was still more growth available to me, and I felt like Bipolar Advantage offered that.
How is it different from other approaches that you had?
The first is the integrated approach. I think that's something that I started to see at Kaiser, but Tom has done a good job of bringing a lot of resources, especially in terms of the workshops that are available. He's brought a lot of resources together that allows one to learn in a variety of avenues of nutrition and biopsychosocial issues and chemical abuse and so on. But what I think was most unique was when I went to the seminars that there's a sense of optimism that I haven't experienced in other mental health settings. I've been to a lot of groups, and generally I'll go to groups, even sponsored ones in a healthcare clinic or whatever, where the attitude tends to be kind of sad. People, they have this illness and their lives aren't going well, and they wish they didn't have it, and gee, the medications are really rotten, and it's just a lot of unhappiness with having the illness. Whereas at the Bipolar Advantage seminars, the attitude was more, well, let's look at the upside. We have sensitive emotions, and we can have more energy than other people sometimes, and maybe we can focus better sometimes, and maybe these are strengths. Maybe having a bipolar condition isn't entirely negative. Maybe we need to look at it as being a variation on a normal mind rather than a totally messed up mind that we should be sorry that we even have. And then the third thing was the encouragement to experience a broader range of emotions, because I really did come from the mindset where I was terrified of depression. I had had such awful depression in my life, I didn't want to go anywhere near it. Of course, I was depressed a lot, but I hated it. I was scared of it. I didn't like it. I dug my feet in trying to stay out of it. And Tom actually introduced the concept, which he has not mentioned, which is that depression can sometimes actually bring something to you. It doesn't necessarily have to always be awful, but you can actually learn from it. And that was such a radical concept when I first heard it, because I hated depression so much. But it's really kind of changed my life.
And give us an example of something you learned from depression.
It's sort of like going to a tragic movie. You go to a sad movie so that you can experience the heartache of humanity, the currents of sorrow that run through our lives. When you're depressed, you're in touch with that. You don't need to go to a sad movie. If you allow yourself to say, yes, this is the human experience. Tragedy has been with us, I'm sure, since we were pre-human primates. Humanity has dealt with tragedy. It's a part of our experience. And to embrace it and say, yes, this is what it feels like. People have felt this way right from the very beginning, and I am there. It broadens your range of experience. It brings you in touch with life.
If I might add to that, there's also this idea that we think that we're weak because we have those experiences, but as we look at them, we find out we're actually strong because we're able to have those experiences. And it becomes a source of strength for us instead of a source of shame or weakness.
So of all of these various aspects of the program, which of them have you brought into play so far?
Like I mentioned, when I came to Tom, I had already worked on much of this. I had already done what I considered a fair amount of spiritual work, and my relationship I felt was in good shape, and I was exercising a lot, and so on. I'd say the biggest change has really been the emotional, that I have more or less, not always, but most of the time I have abandoned the idea that I need to constrain my emotions as much. I mean, I don't want to get so depressed that I curl up into a ball and can't function. You know, obviously that's too much depression. At least right now, it is for me. So I try to avoid what I consider too much for me right now, but I go much further than I used to. And I think it helped that I came into this with the cognitive tools to modulate my depression already, so that if it starts to feel like it's getting to be too much, I have some skills that allow me to pull back. I feel like I have some modicum of control over my moods, and that helps me feel safe when I expand my range and go into zones that I used to be afraid of.
I'm going to give a challenge to the audience, for those of you who are watching this. Do you know someone who is living with a mental condition who might not be looking at all aspects of his or her life, physical, mental, spiritual, relationships, work? Maybe this is someone you know, maybe it is you. I'd like for you to think about what you've heard in this show and think about whether you've learned anything from this approach that might be helpful in the situation you're thinking about. So that's your assignment. I'll leave you with some resources. The Bipolar Advantage website is on your screen, www.bipolaradvantage.com. Tom Wootton's 2 books, Depression Advantage, The Bipolar Advantage, and a new one that's going to be coming out soon called Bipolar in Order, describing his new technique. Peter's Psychiatric Association, Gateway Psychiatric Services. You can find that on the net at gatewaypsychiatric.com. And Will Meacham has a website with a blog in which many of these ideas about spirituality and so forth are developed, and it's at willspirit.com. I'd like to close with these words from the Reverend Wayne Arneson. Take courage, friends. The way is often hard. The path is never clear, and the stakes are very high. Take courage, for deep down, there is another truth. You are not alone. Thank you for watching. We'll see you next time.